Now I have got the very pleasant duty of introducing our international guest speaker, Dr. Fazila Tunnesa Malik. But before that, I will call upon the chairpersons, Dr. Shandip Mishra, please. Dr. N.N. Khanna, please. Dr. Achyut Sharkar. Is Dr. Achyut Sharkar here? Dr. Mohanan, will you please chair? It's a guest lecture by Dr. Fazila Tunnesa Malik on left main, but you introduce, please.
Good morning, everybody. I think there's no need to introduce Dr. Fazila. I think everybody knows her, even internationally, and of course in this part of the world, she is extremely well known. And so I think without further ado, I think, and I must remind you that you are listening to one of the top international cardiologists in this part of the world. And I hear that she has got a very big series on left main interventions. So we are really grateful that she is going to talk to us about left main interventions. Professor Fazila, please.
Thank you so much. It's overwhelming, your kindness and what you've said. I really don't deserve it. India is like our second home for all of us, and especially Kolkata. So thank you so much for inviting me over and for giving me this opportunity. And thank you for your kind words once again. So today I'm going to talk about left main PCI. And I actually work at the National Heart Foundation Hospital and Research Institute, which is a 330-bedded tertiary cardiac care hospital in Mirpur, Dhaka. We are a non-government, non-profit organization developed under public-private partnership, and we try to provide modern cardiac treatment to our patients at an affordable cost. We started our journey in 1999 with a single cath lab. At present, we've got 3 fully functioning cath labs, and up till December 2016, we have done a total of 27,000 PCI. We started doing left main PCI in 2007, and up till November 2016, we did a total of 1,058 left main PCI. Of these 1,058 patients, we were able to, the value isn't coming, I'm very sorry, when you transferred the values, I think the values got lost there, it's just writing values. Well, of these 1,058 patients, we were able to follow up 980 of them. 67 were lost to follow up, and a few number, their follow-up period was below 1 month. So the vast majority of our patients we were able to follow, and the median follow-up period was 25 months. And of these 910 patients, the total patients we found, 910 patients, which was 95% of our patients were doing well. And our overall MACE was 5%. And after doing left main PCI for nearly 10 years now, I fully agree with the editorial that Dr. Eugene Brunwald wrote for the EXCEL trial. And what he wrote was that the take-home message for the EXCEL trial is that the majority of patients with unprotected left main coronary artery disease, which was a very serious, life-shortening and disabling condition early in my professional lifetime, can now be managed equally well by means of 2 strategies of revascularization, if carried out by experienced teams such as those participating in the EXCEL trial. The outcome of shorter hospital stay, greater early safety benefit, and more rapid recovery and return to normal activity favor PCI over CABG. And I think that really sums up why we go on doing left main PCI, because our patients really do benefit from the shorter hospital stay and the lesser invasive left main PCI. But you will all agree that in this part of the world, we've got such a huge diabetic population. And when we are dealing with left main PCI patients, it's not uncommon to find that these patients are diabetic as well. And if you look at different trials which dealt with diabetic patients with PCI, like the FREEDOM, etc., CABG, of course, is better off in diabetic patients. And that's why we wanted to study our patients who came to us, and we treated them with left main PCI, and these patients were diabetic as well. I really apologize. I gave the pen drive, but it's already only showing value. There must have been some virus or something, so the value isn't coming. So of the patients that we did left main PCI, 494 were diabetic. So they were left main PCI patients and they were diabetic. This accounted for 52% of our cases, and 48% of our patients were, that is 466% of our study population were non-diabetic. So a vast majority of our patients with left main PCI were diabetic. And if you look at their age distribution, the vast majority were both in the diabetic group and as well as in the non-diabetic group were above the age of 50. And indeed, in both groups, around 12% were above the age of 70, which is a fairly elderly group. Interestingly, the mean age was statistically higher in the diabetic patients. So our left main PCI group with diabetes, they were more older than the non-diabetic patients. And if you consider the sex distribution in both groups, diabetic and non-diabetic, the overwhelming majority was male patients, and around only 20% in either group were female patients. Considering the risk factors, our diabetic patients were really sick who underwent left main PCI. They were significantly more hypertensive than the non-diabetic left main PCI group. Smoking was almost equal in both groups. Dyslipidemia and obesity was numerically higher in the diabetic group, but this did not get statistical significance. And regarding the diagnosis, in either group, almost half of the patients were coming with chronic stable angina and the other half with acute coronary syndrome. Considering the ejection fraction, in both groups, the vast majority, and that is 62% of our patients in either group had good ejection, left ventricular ejection fraction, and that was, I think, a real help. However, it goes also that around nearly 38% of our patients in either group had some form or other of LV systolic dysfunction. If you look at the angiographic findings, our non-diabetic patients had left main with a single vessel disease, whereas the diabetic group had multi-vessel disease, and this was more statistically, this was significant. Regarding the procedure, in the non-diabetic group, we were able to get away with pre-dilatation in certain scenarios, but in the diabetic group, pre-dilatation was absolutely done in majority of patients. Post-dilatation for either group, we did irrespective of whether they were diabetic or non-diabetic. The stent length was somewhat longer numerically in the diabetic group compared to the non-diabetic. The stent diameter in either group was 3.6 average. And regarding the stent strategy, in both diabetic and non-diabetic patients with left main disease, single stent strategy was our preferred mode of dealing with these patients, and in either group, double stent strategy was only used in around 12 to 13% of patients. And what about the generation of stent? We used second and third generation stents in our vast majority of patients in either group, more than 89% in the diabetic and 84% in our non-diabetic group. Zotorilimus eluting stent was the most commonly used stent in either group, closely followed by everolimus eluting stents. And if you consider a death repeat revascularization, it was almost same in both groups, and are if you consider death and repeat revascularization according to the generation of stent, the second and third generation stents had the lowest degree of MACE compared to the first generation stents. And about the diabetic patients, 52% of our patients were on insulin and oral medication, 45% were only on oral medication, and 3% were on irregular or no medication. Regarding whether the patients were diabetic or non-diabetic, 95% of our patients were on DAPT, prolonged DAPT, 5% were irregular on that. And after this, what we felt that left main PCI in a diabetic patient is a feasible procedure with good long-term results if the patient's ejection fraction is good. That makes the procedure such a lot easier. If you use a single stent strategy as your default technique and try to keep the technique as simple as possible, use the second and third generation drug-eluting stents, do optimal pre and post dilatations, and use DAPT for a prolonged period. Now, after doing nearly more than 1,000 cases in our center, I think we've come up with certain tips and tricks. Most of you are fully aware of those ideas because they're very common, but still just a brief recap of what tips work and what helps in doing a seamless left main procedure. Well, when we are dealing with an austere left main, obviously using a short-tipped guide catheter really helps. And once the wire has been positioned, it's good to disengage the guide catheter slightly. During positioning of the stent, guides need to be completely removed from the left main. 1 or 2 millimeters of the stent, when it's an austere left main PCI, has to protrude in the aorta, but you do not want a huge amount protruding. So ideally 1 or 2 millimeters will have to protrude. Balloon inflation times should be short, less than 30 seconds, because there's this huge amount of myocardium that we will be depriving of blood supply. So the balloon inflations have to be short. And the proximal end of the stent needs to be flared at the end of the procedure by pulling back the balloon and going up high again. So that's for austere left main. And usually, following these small tips, the final results are usually good. And 3 years down the road, the results are still doing phenomenally well. Sometimes left main come with different difficult scenarios, like this post-AVR patient who had a severe austere left main. Now, when there's a difficult situation, obviously gentle handling has to be the prerequisite. So gentle handling, absolutely gentle handling, and to place the stent always in the left main, one has to be very, very sure of the proper positioning. So different orthogonal views are needed for proper placement of the stent. And the final result with gentle handling in a difficult situation is usually satisfactory. So take your time and be gentle as possible when dealing with a left main PCI. Sometimes a simple angiogram can lead to potential disaster. Like in this case, a simple angiogram was being done and there was iatrogenic dissection of the left main. During angiogram, the patient became hemodynamically unstable. So immediately we had to change to a guide catheter, wire the vessel, and in this case, no pre-dilatation, we just did direct stenting. So one really has to be very, very careful while doing an angiogram because we are dealing with the left main and you always want your catheter to be coaxial. This is something that we all always need to remember. And the final result, we took a 4x12 drug-eluting stent and the final result was good and the patient settled. Now, one thing that when we deal with the left main, we need to remember is that the left main has the highest elastic content compared to any artery. And so we need to put a when we're planning to stent this vessel, we need to have a stent that gives us good radial strength. Otherwise, there can be unforeseen accidents and catastrophes. Like we were dealing with this ostial left main lesion. After pre-dilatation, we took a 4x12 drug-eluting stent, dilated it, did post-dilatation, things look good. But immediately after stent deployment, you can appreciate that the stent has collapsed on itself and the patient started being symptomatic. So obviously this stent could not withhold the radial strength, did not have the radial strength to withhold the recoil of the left main. So what we had to do is, we immediately took another stent and deployed it there. And the final result was good. So while dealing with left main PCI, one good tip to remember is always choose a stent which gives adequate radial strength. Sometimes left main lesions can be very complex with ramus, then with a very large LCX, etc. Like this distal left main, which was a trifurcation lesion, and the LAD was a CTO. So the lesion can be complex, but the strategy should be to keep it as simple and short as possible. And so here, after we opened up the CTO of the LAD and did pre-dilatation, we just used a single stent from the left main to the LAD. And the final result was good. And check angiogram after 3 years shows that the result is great. And sometimes imaging can give you an idea of whether you can get away with a single stent strategy. And when you do a single stent strategy, obviously a stent that gives you, that will help you preserve your side branch is also a good technique to choose. Now, in this case, this was a post-CABG severely calcified left main stenosis, which was also involving the proximal part of the LAD. And it was so, there was a dominant RCA which also was severely diseased. So obviously, when you have multivessel disease, a smart thing is to stage your procedure, do the other vessel, and then once you've stabilized the patient, go and tackle the left main. So that's what we did. We corrected the lesions in the RCA first. After that, we went on for the left main. There was such a huge amount of calcium in the left main that we were having a struggle with the wire. So a microcatheter helped us in wiring the vessel. And once we wired that vessel, we knew that we would be unable to do any kind of procedure in this left main without a rota. So we exchanged it for a rota wire and did a rota run with a 1.25 burr. After this, we took a IVUS catheter and had a look. And we saw that the arc of the superficial calcium was around more than 360 degrees. And we had just managed to get a bit of it scraped away with our 1.25 millimeter burr. So that made us use a second burr, a 1.5 burr now, to do a better job of removing this superficial calcium. After this, this is how the vessel looked. We rewired our LCX. And then we had a look at the LCX origin again with our IVUS. And we were very happy to know that the IVA showed us that the LCX ostia was free of disease. And this made us realize that we would get away with a single stent strategy here. So after pre-dilatation, we took a 4/34 disc from the left main to the LAD. And our final result was good. So imaging does help. And indeed, up to 80% of left main lesions will involve the bifurcation. So you need a stent which will allow you greater side branch accessibility, which will not compromise your side branch, and that is important to remember. And sometimes the bifurcation lesion can be so complex that you know from the very beginning that you will not be able to get away with a single stent strategy. So decide on a double stent strategy early on and work towards it. So with left main PCI, one shouldn't do it on an ad hoc basis. It should always have a strategy, and that strategy should be followed. So here we stented from the left main to the LCX, rewired the LAD, did a second stent from the left main to the LAD, and when a double stent strategy is used, we all understand that final kissing is absolutely mandatory for good long-term results. And in this kind of complex procedure where double stents are used, an imaging technique like IVUS can help you to guide whether you need further post-dilatation, what kind of kissing results you got, etc. So IVUS can be a very valuable tool here. Now, aorto-ostial lesions are very tricky, and a proper positioning of your stent is obviously mandatory, as we were saying earlier. So a stent that gives you a good visual, it's good and adequately visualized, does help. Now, in this very tight, heavily calcified ostial lesion, we decided to use rota early on. And it has been our experience that for heavily calcified left main lesions, the best strategy is to use your rota as early as possible. This saves time, and it also protects your patient from needless ischemia. So after rota and pre-dilatation, a stent was taken, and the final result was satisfactory. Another thing about left main is proper sizing. We need to remember that 75% of left main diameters are more than 4 millimeter. And so you need to properly size your stents. And in this case, we did a pre-IVUS for this left main, and we found that the size of the left main was more than 5 millimeters. So we took a 5/26 drug-eluting stent for this patient, deployed it. And for the LCX, we took a 3.5/30. Final angiography looked good, and the IVUS also revealed that the stent was properly sized and well apposed to the left main. So sizing, as I was saying before, sizing is crucial for left main PCI. And here, just to illustrate this again, in this severely ostial left main disease, after pre-dilatation, a 3.5/8 drug-eluting stent was taken. We deployed the stent, did post-dilatation. We see that the stent is present, and then in the next shot, we can't see our stent. So where is the stent? The stent isn't in the left main, and our patient has started complaining of chest pain. So instead of going hunting for our stent, we took another 4/15 drug-eluting stent and immediately deployed it at the site of the lost stent. And the final result was good. We then went looking for our stent and found it outside of our catheter and took a snare and removed it. And in many instances, left main happens in post-CABG patients. Post-CABG patients usually have heavily calcified vessels, and for tortuous, heavily calcified vessels, always take a stent that is very, very deliverable. So for this elderly post-CABG patient with severely calcified left main to LCX lesion, after rotablation, we did pre-dilatation with an NC balloon. We used a very simple technique, the cuspal wire technique, to identify our ostia, and then we deployed our stent, which was very easy to go because it was highly deliverable, and this was the final result. And sometimes left main can have such a dramatic presentation, like this 43-year-old male who was rushed to our cath lab in a collapsed state. After defibrillation, complete heart block was detected, TPM was done. The pictures aren't here. So his left side was totally occluded. And I'm sorry that I think there's some problem occurred when we transferred the pictures from the pen drive because the values didn't come, and in this last case also, unfortunately, the pictures didn't come. So basically his heart was barely moving, and we managed to do, as CPO was going on, we managed to do his PCI, and we deployed a stent. The pictures aren't moving, I'm sorry about that. And eventually this patient survived, and we did a check angiogram after 21 months, and he's doing well. So left main PCI, my take-home message would be, for optimizing outcomes of left main PCI, we need a stent of proper size, good radial stent, good radiopacity, excellent side branch accessibility and deliverability. We need proper tools like IVUS, ROTA, NC balloons, and we need to strategize, decide on a proper strategy, and keep it as simple as possible. And from our Heart Foundation team, thank you.
Thank you, Professor Fasila, for your tips and tricks on left main stenting. We also appreciated your 2 left main live cases yesterday. Also, when the compilation of the data that you showed, which is almost akin to the Excel number, but I should also say that while we cardiologists bank on Excel data showing the superiority of the PCI, the surgeons bank on Noble data and say still CABG may be superior to the left main stenting. But then having said that, I think we are evolving to a process by each of these processes will have the best suited to the ideal patient. You will conclude.
So I think, what we have come to now is that left main PCI is it's becoming kind of gold standard, although surgery still exists because of ease and, all the follow-up, etc. Your data was very interesting, and I think more interesting part was that more than 50% were diabetic. I think you should separately present them. I just wanted to know, in how many percentage was IVUS, etc. used in your cases?
Well, actually, we have not been using that much of IVUS. Our total use of IVUS is around 13%. But we have decided that we will be using more of IVUS from now on. And actually, after using IVUS, we realized that in many cases we had undersized our stents. That's why our average now is 3.6 millimeter our diameter. Because nowadays, for most of our left mains, we're using stents more than 4 millimeters after the use of IVUS.
I think, thank you very much, ma'am. We have so many questions, but I think the time is over, so over to Dr. Soumitra Ray. Please give her a big hand.
Yeah, thank you, our international speaker, Dr. Fazila Malik, and the chairpersons. Thank you for conducting the session.